Well, thank you very much, but I think we'll see that there are really hundreds of people that helped with this, and it really is an interesting story to try to look and see how do we really create impact with what we're doing. I have no disclosures. I wish I did. In working in different countries, I think it's important to understand a little bit about the countries we work in. And so as you look at Mongolia, I really didn't know too much about Mongolia when I was first invited to go there. I just thought it was cold and it was a place where Genghis Khan just kind of killed everyone. But he was born in 1162, and in 1206, he actually organized the Mongolian Empire. It's his children and grandchildren that took it and made this huge empire to be the largest empire in the world. And what I didn't know were these things about Genghis Khan. He liberated the Mongolians from foreign rule. He united the people, created an alphabet, wrote the Constitution, established universal religious freedom, one of the first places to do that, invented a new system of warfare, that I did know, marched an army across continents, opened roads of commerce in a free trade zone that stretched across the continents, and created the first international postal system. Now, Mongolia fell to Chinese rule from the late 1300s to about 1911. And then after they left, the Russians came in 1922, and they occupied the country. When the Berlin Wall came down, Russia ended up leaving Mongolia, taking everything off the shelves, all the cars, all the jeeps, all the things that they brought. They'd done some great things, building wells and hospitals, but they took everything with them. So that when I came to Mongolia in 2005, it was the most sparsely populated country in the world. 49% of the population resided still in the rural areas and lived a nomadic lifestyle. And their vast rural areas were really isolated, creating significant challenges in providing access to health care. And how were we really going to work in this environment where the economy really was at one of the lowest areas of the world? And I thought that there are barriers. I didn't go to Mongolia to teach laparoscopy. I went there to teach trauma, because I felt like that just wasn't a good place to go teach laparoscopy. There's several barriers. One was a perception that many people had that MIS should not even be taught in low and middle income countries. Just poverty. Infrastructure was lacking: electricity, water, equipment, language barriers. They only spoke Mongolian. Educational content: what were we going to use? Where were we going to start? What kind of business model would support this? And they just didn't even know that they needed laparoscopy in most of the country. A few of the doctors did. What I want to do was highlight 6 of the many, many, many people that made this happen. And without these 6 people, it would not have happened. Chuck Swanson, there on the right, that's actually part of our SWAT training team with the foundation we worked with in Mongolia as well. Now, putting that together with healthcare was kind of interesting for me, but it created a really interesting trust relationship between Mongolia and this private NGO that Chuck Swanson ran. I'm going to talk about each of these people as we go, but it's really important to know that successful, sustainable progress is likely to be achieved when local parties have helped identify the specific needs and are passionate and motivated to find locally appropriate solutions. So when I first went to Mongolia, I knew that the World Health Organization had begun a program just the year before, the Global Initiative for Emergency and Essential Surgical Care. It was the first coordinated effort to address the absence of adequate capacity for emergency and essential surgical care services in low and middle income countries. They were reaching out to rural hospitals, district hospitals, primary health care facilities, and health centers, teaching surgery, anesthesia, obstetrics, and orthopedics. What I didn't know, that Dr. Segerlin, one of those people on that previous slide, was highly engaged in developing this program across the country of Mongolia. They were bringing people in from all sorts of different areas and training in certain areas around the country. That helps us in our laparoscopic expansion. She went ahead and told me a story when I got to Mongolia, and I was invited to come over from the trauma hospital to learn about what they were doing in laparoscopy. Dr. Segerlin told me that in 1994, Buck Rusher, one of those first 6 people there, had come over in 1994 and began to work with Dr. Gonbold, an anesthesiologist, Dr. Nimhu, who is currently known as the father of laparoscopy in Mongolia, and Okendaya. He taught them a little bit about laparoscopy, brought them over to the United States, and had them come back to Mongolia to perform their first laparoscopic cholecystectomy together. They celebrated that night and went out for dinner. They all got food poisoning, and Dr. Okendaya died. there's some challenges in developing these kinds of things. By the time I went there in 2005, only 2% of the gallbladders were being performed laparoscopically, and only in the capital city. Dr. Segerlin gave me a little PowerPoint talk, and she'd given this to the World Health Organization, and she was turned away. She said that with open cholecystectomy, we have a 12.5% incidence of wound infection. With a few laparoscopies being done, it's 1.3%. People stayed in the hospital so long with open cholecystectomy, but laparoscopy went home the same day. And her slide said this: introduction and further development of laparoscopic surgery in Mongolian surgical practice is demanded. How do we do that? I thought this was nuts. This is crazy. We came back to the United States and we had multiple emails back and forth. What would we do? The foundation was able to get some laparoscopic equipment along with all the other equipment we were supplying to 39 different hospitals throughout the country. And we took a team over and they invited 45 surgeons from around the country to come to the training course. This training course, we learned a lot of things. Trying to teach 45 surgeons how to do laparoscopic cholecystectomy in 2 weeks doesn't work. Everybody wanted to get their hands on. Nobody got any sustainable change, and so we had to go back to the drawing board to figure out how could we do this differently. We found many problems. You look at the long instruments that we have, but you look at the way they had to sterilize things. They put them in these containers. They didn't fit. How are we going to sterilize all the equipment? They had a magic box. They put formaldehyde down on the bottom. They put things in there and let it sit there for 8 hours, and that was supposed to sterilize it. So we had to overcome and develop a sterilization capability. The equipment damage, we had so many people in the operating room, they'd trip over the cords and they'd plug it back in and it would blow out our light sources. And so we had many challenges that we had to figure out how to overcome. We learned that developing and bringing new technology to a new environment requires a lot of issues. It requires understanding the quality assurance, understanding local regulations that I had never thought about. The education was much more than just teaching a surgeon how to do surgery. It required an entire team, financial sustainability, and what kind of political support did we have. After that first trip, we went back to develop a little different plan, what was going to work. We came up with a program, and we had to bring still lots of resources into the country. We shipped containers. We were actually bringing hospital beds, x-ray machines. We put in actually the first angio suite in the country. But we brought the laparoscopic equipment to set up the rooms. We partnered with SAGES and got permission to use the first 4 lectures of FLS, to have that be the first part of our standardized training education program. And then we went ahead and developed our really clinical training teams with 2 surgeons, an anesthetist, operating room nurse, scrub tech, a biotechnician, was proved to be one of the most critical people in the teams, and then surgical residents to do some research, of which I have one of my previous residents here with me today, and I'll show you what she did. Our team wasn't just teaching laparoscopy, though. We had multiple education programs that were going on. I think this is what brought trust with the government, with the hospital system, and with the people. We responded to all the requests that they had, or at least as many as we possibly could, developing formal courses or using formal courses that we got permissions to use. The teaching method, we thought, well, let's try. Can we teach 2 surgeons in 2 weeks if they were to do 3 lap choles a day, where they began as an assistant surgeon, then become a surgeon, and then only Mongolian to Mongolian? Could we, in 2 weeks, transfer that type of skills safely during that time period? We weren't sure. So Dr. Kate Straub, who is one of my previous residents, is now 10 years out or so, came with us on her own dime, and to help us be able to study the outcomes of laparoscopic cholecystectomy in the capital Ulaanbaatar and compare it to the first city outside of the capital where we took this, into Erden. And after 18 months, we showed that actually the outcomes were no different. And it gave us some hope that maybe our teaching model was safe. So when Dr. Segerlin came to me then and said, we need you to take this to all 4 quadrants of the country. Oh my gosh, what are you talking about, woman? She is the most smart, most visionary woman I have ever met. And so we listened to Dr. Segerlin as how do we do this? We needed more people, we needed volunteers, we needed equipment and supplies, partnering with industry in so many ways. That's why I have Mrs. Stortz at the beginning. I spend most of my time in the American College of Surgeons down on the industry floor, talking to the various people, working on ways that we can partner to try to develop these kind of programs. and really became helpful in expanding surgery throughout the country that would not have happened without their help. Covidian, we had actually developed representatives in the country, surgeons that became the distributorship, because there was no distributorship. There was no business to support this. How were we going to develop this? So we went from this donation equipment that we would get up to quality that we could use in the US, but when it broke, it would not be fixable. And so we had to go to brand new equipment with all the various partners. And we partnered with SAGES in terms of bringing more people, more teams to be able to go throughout the country. How were we going to develop the supply line? I actually posed this to Mrs. Storch, said, how do we keep your equipment functioning? So she sent her representatives from Irkutsk and Moscow down to Hovd and developed a supply line in the country. What about training residents? You've heard about some phenomenal training programs here with SAGES, and in Costa Rica and in Mexico. We started backwards. We kind of went backwards to training surgeons. There's no surgeons really that knew how to do laparoscopy where we were training. But how do we get into the residency training program? So we developed a Train the Trainer program in 2009. We actually connected the operating rooms with a conference room, and they could see in 2 operating rooms inside the patient and in the operating room, had 2-way communication. So we could teach 100 people, but have only 2 surgeons in each of those operating rooms. I came back in 2015. After teaching this in 2009, they said, Ray, come see your vision. I said, what do you mean? And they took me to this laparoscopic training facility, really high tech, where they have residents now spend 1 month of their 1.5-year training program is now into 2 years doing laparoscopy skills training. Dr. Erden, I mentioned, he's one of those people on the front page. Those 6 people, he's the one who became the laparoscopic training program director at the residency program, and even went on to develop a 6-month fellowship where he brings surgeons in for 6 months, or for 5 months, and then the last 6 months he also brings in the surgical staff, the nurses and the techs, so they can learn how to do it throughout the country. How do we do this with people? When we first got there, many of the patients said, I don't want those little holes. How can you see? I want you to make that big hole so you can put your hand in there and take out the gallbladder. It was Dr. Masaihan here, who was the hospital director up in Erden, that says, can you go on live call-in talk show TV in Mongolia to answer questions about Mongolia, about laparoscopy? So we did, and it's where he taught me that we need to educate the population about how well they're doing. This is actually the TV pictures. People begin to know and trust their doctors. They begin to come to the hospital more. This was really a health system strengthening program. Dr. Segerlin stated laparoscopic surgery is more important for developing countries than high-income countries. Now, I'm not sure that's really true. It's important for everybody, but it is dramatically helpful for the economies in low and middle-income countries. What happened over many years, our teams taught in the maroon areas. This is a slide from previously. We've actually taught in several other areas, but laparoscopy is now in 19 of 21 provinces. This is not just from us. This is the teams in Mongolia that reach out and teach their people in Mongolia as well. By 2011, laparoscopy became the primary way to remove the gallbladder. It's currently 80% or more of the gallbladders are removed laparoscopically now in Mongolia. This is the last little story to show you about in Mongolia, what changes happened. This is in 2019, my last trip before COVID hit. We went way down south to the Gobi. This lady brought out, she's holding in her hand her box of gallstones that were removed by an open cholecystectomy by this surgeon in 2011. This is this lady's sister. This lady went up and did that 6-month training fellowship with Dr. Erden. And then when we came down, she took her gallbladder out laparoscopically. This is her 1-day post-op, about 70 kilometers from the town. There's nobody else living around here in this area. We got some drone shots showing how remote this area is. This is sustainable change. This is what happens. They've gone ahead and developed their laparoscopic and endoscopic surgical society. They've had now multiple meetings. This is the first one. And when we first went to Mongolia, one of our lecturers was trying to set up guidelines. We brought the SAGES guidelines. He said, we can't do that. We have those guidelines. The government will see that. If we don't do that, they'll throw us in jail. They then came back a few years ago, said, Ray, We need guidelines, and they brought together SAGES guidelines, EARCAT guidelines, the Italian guidelines, the Japanese guidelines, and put it into what they call the Ulaanbaatar recommendations. I'd like to finish with this. If the people see the service as meaningful to their lives, if it is compatible with their norms and values, if they feel a sense of ownership and support from people they respect, then there will be an incentive and motivation to maintain it. Thank you very much.